All right. Welcome, guys. This is Dr. Price with Action Potential Mentoring, and we're going to cover the top 20 things that you need to know from NBME 12 for the USMLE Step 2 CK before you sit for your exam. So this is a video you absolutely want to come back to, one that you do not want to skip prior to sitting for your USMLE Step 2. So here is our social medias if you want to stay connected. I'm most active on Twitter. You can find me at action_AP. And I'm going to go over this because I think it's the hardest NBME. And so I want to make sure you guys know the 20 most important facts, things that people miss every single year. And so keep in mind, you don't want to watch this yet if you haven't taken NBME 12 yet. So put this in your watch later list if you haven't taken NBME 12. I don't want to artificially inflate your scores and ruin your measurement tracking of your progress. So with that being said, let's jump right into it. All right, so you see a patient that has a collapsed lung, aka a pneumothorax. And so you're going to get a chest x-ray for these questions. The treatment is going to be tube thoracostomy. And so you don't want to get thrown off because most people look for the answer choice of needle decompression or chest tube. But on the NBME, they're usually going to look for the term tube thoracostomy. That's just a more ornate way of saying chest tube. And so generally you want to find the fifth intercostal space, mid-axillary line, throw in a chest tube. And so that's going to help the lung inflate because remember, when you have a pneumothorax, the intrapleural pressure goes to zero. It's going to essentially equilibrate with the atmosphere, which is 0 ATMs. And so you want that intrapleural pressure to get back to -5 like it was before the patient had a pneumothorax. And so you put in the tube thoracostomy to help these patients. All right, next, to diagnose ITP, immune thrombocytopenic purpura. This is one of the most high yield topics on the entire exam. It's generally going to be first diagnosed in a younger patient, so they could be 5 to 15 years old, most commonly on the NBME. Not to say it couldn't be a 40-year-old, but just keep that in mind. They're often going to be symptomatic, such as bleeding. They could have mucosal bleeding. They could have epistaxis. They could have some bleeding that's a little bit heavier during menses. And generally, they're going to have low platelets. And so the cutoff that the NBME most likely is going to use is 30,000 platelets or less. So regardless of which resource that you read, whether it's first aid, whether it's the NBME, whether it's UWorld, whether it's USMLE RX, resources can have different cutoffs for ITP. Even the American Academy of Family Practice physicians can have different cutoffs, but generally the NBME is going to go with platelets less than 30,000. And so in these patients, your bleeding time is going to be increased. You really want to know this. This is a platelet deficiency, right? And so the platelets are going to look totally normal in the peripheral smear. This is different than something like gray platelet syndrome, where they don't have the alpha granules. And so on a peripheral smear, it looks like all the platelets are going to be gray. This is not that. This is different. So it's just a deficiency. The platelets are not actually lacking anything intrinsically that is going to affect their shape or affect their appearance on peripheral smear. And so these patients, you want to treat them if they are bleeding. So if they have symptoms and they're bleeding, you want to give them steroids. If the steroids don't work, give them IVIG. If IVIG doesn't work, give them rituximab. If rituximab doesn't work, do a splenectomy. Or if they are hemorrhaging, like aggressively, they're unstable, the question is going to expect you to jump straight to splenectomy to fix the problem right at the source. Okay, so start from least invasive to most invasive unless the patient is in critical condition and they're bleeding, they're requiring blood transfusions. Then you can go straight to splenectomy. So one thing I want to get straight here is if this is in a pediatric patient, then you don't just treat them if they're asymptomatic. Generally, those patients you just leave. Whereas if it's an adult and the platelets are less than 30,000, you can just go ahead and prophylactically give them the steroids. All right, number 3. If you see a patient that you suspect CHF, they've got all the symptoms like an S3 heart sound, which indicates fluid overload. They might have crackles in their lungs. They might have JVD, which is jugular venous distension. Their IJ looks like it's distended on ultrasound, or you can even see it peripherally through physical exam. But these patients don't have lower extremity edema. Don't get tripped up. This question messes up a lot of students because they see that there's no peripheral edema in their lower extremities and they're like, oh, it couldn't be CHF because CHF always has that. Well, keep in mind that CHF does not have to have lower extremity swelling to be considered CHF. If it's not end-stage CHF, then these patients might be totally asymptomatic in their lower extremities. So it's not mandatory. Keep that in mind. Number 4, Sinusitis. This is something that, for whatever reason, trips up a lot of people. And so keep in mind that for ICU type questions, and you could see this on your IM shelf or your surgery shelf as well, patients that have endotracheal or nasogastric tubes, they can have a higher risk of sinusitis due to decreased sinus drainage from the tube being down their airway or their oral passage. And so, how do you diagnose sinusitis? Generally, you're going to want to get a CT of the head. It's going to show some fluid levels inside of the sinuses. These patients often have elevated white blood cell counts, and they oftentimes are going to have fevers, especially if they're immunocompromised. And so, if there's no fever, but you have a clinical diagnosis as well as even a CT showing that there's sinusitis, you don't do anything for 7 days. So, you give them supportive therapy, you give them fluids, that kind of stuff. You can give them Tylenol if you want for symptoms. Uh, but if there's no fever, you don't need to jump to the antibiotics yet. In real life, oftentimes people are just going to throw you on antibiotics, but for the NBME and the USMLE, you don't put them on antibiotics unless they have severe symptoms or there's a fever. And so, if there is a fever or supportive therapy has failed, you're going to jump to Augmentin for 10 to 14 days. I just keep it simple in my head and say Augmentin, 2 weeks, done. All right. And so, that's what you do for sinusitis. But don't forget about chronic sinusitis. So, chronic sinusitis is sinusitis that does not resolve with antibiotic treatment. It's kind of just smoldering there for a long period of time. And so, these patients often show some improvement with macrolides like azithromycin or steroids. But if this fails, then you want to send them over to your ENT colleagues for surgical sinusotomy to help improve the drainage by basically opening up the sinuses and allowing that fluid to drain out. If these patients are immunocompromised, you're going to see fungal infections of the sinuses more commonly, such as aspergillosis, stuff like that. These patients get amphotericin B and then oftentimes surgical removal if there's fungal balls present. All right. What do you do in a patient where you suspect an opioid overdose? You want to get an ABG stat. And so the reason to do that, an arterial blood gas, is to look for hypercarbia. And that's going to be a retention of your CO2. Patients that have opioid overdoses, they're going to have a very, very low respiratory rate. So they're not breathing out all their CO2 levels. So these patients will have a respiratory rate that's less than 10 in most question stems. So if you see a respiratory rate of like 5 or 6 or 7, you know that there's a reason that they have respiratory suppression. So opioid overdose is one of the most commonly tested concepts for respiratory suppression on the NBMEs. All right, number 6 here, osteoarthritis. How do you treat it? You want to treat with Tylenol, aka acetaminophen. And you guys might have kind of caught on to this so far, but everything in this document that's yellow is a treatment. Everything that's orange is going to be a diagnostic criteria or a diagnostic tool. Okay, so on the other hand, from osteoarthritis, I remember that rheumatoid arthritis is worse when you wake up in your room. So I remember it as rheumatoid arthritis, aka it's worse in the morning. So I don't know, this mnemonic worked for me. I hope it helps you remember that rheumatoid arthritis is worse when you wake up in your room in the morning. All right. The pre-op workup for somebody with angina, what do you do? Cardiac stress test. And they could put a ton of different things. They could say cardiac scintigraphy. They could say regadenoson stress test. They could say exercise treadmill stress test. There's all kinds of different stress tests. But keep in mind, the big overarching thing you want to look for is some sort of a cardiac stress test. So that's not very difficult. But the thing that's very difficult about this is you can get tripped up on the USMLE if you miss atypical angina workup. And so atypical angina is often in females or diabetics or patients with severe peripheral arterial disease. And so they can get symptoms like nausea, emesis, or epigastric pain. Super, super high yield to know because they're not going to give you a typical angina pectoris question on your USMLE. They're going to give you atypical angina to try and trip you up of what's the next step. Obviously, if somebody has chest pain, that's classic for angina. You want to work that up, stress tests, etc. But if it's atypical angina, that's a little bit more tricky. So keep that in your differential. All right, number 8. When do you need to go to pulmonary rehab if you have COPD? And so if you have gold classification B, C, or D, which is basically moderate to severe COPD, then you want to go to pulmonary rehab. And so for your family medicine shelf, you absolutely want to know that pulmonary rehab will improve the quality of life, number 1. Number 2, it can reduce hospital readmissions. And then number 3, it can also reduce the duration of stay during your exacerbations. they could ask you all three of those concepts in regards to pulmonary rehab for COPD. All right, number 9. Should you switch patients with bipolar disease off of their lithium during pregnancy, even if they appear mentally stable? So it's tricky because if they were having a bunch of psychotic breakdowns, they were showing bipolar symptoms all the time, obviously you don't want to take them off their medications. But what if they appear semi stable? Well, oftentimes you want to keep them on the lithium, especially if they present to you after their first trimester, because at that point, your organogenesis is basically done from weeks 3 through 8. So if it's after that, you're pretty much, if the harm's done, the harm's done. And so the risk of having a bipolar episode, having mania or severe depression during pregnancy is huge. So you don't want to take them off of their medications if they're already past that first trimester, 3 to 8 week mark. So what do you want to watch out for in babies that are born to patients taking lithium? Number one high yield to know is Epstein anomaly. And so you want to look for a downwardly displaced tricuspid valve. So you're going to have a huge right atrium on an echo, and your right ventricle is going to be small and squished down because the atrium basically atrializes into that ventricular space. And so the treatment for Epstein anomaly is PGE1 as well as surgery. All right, and so something that I have not seen tested yet, but I almost guarantee it shows up in future test questions, is the high yield association between Wolff-Parkinson-White and supraventricular tachycardia with Epstein anomaly. So you have to keep that in the back of your mind. They love associations on the USMLE Step 2. All right, halfway there. Number 10, if a patient is obese and pregnant, you want to keep in mind that you should counsel the patient on not gaining a lot of weight in pregnancy. This sounds kind of like aggressive or something that would be a touchy subject, but for the USMLE, they really want you to know that if your BMI is over 30, you should not be gaining a massive amount of weight during pregnancy. And a lot of students are not going to memorize all the exact weight cutoffs of how much you should gain based upon your BMI. I personally never memorized it. And just knowing this concept of if you're overweight, you don't want to gain a crap load of weight during pregnancy was enough to get me through. So I never felt that those weight criterias versus your BMI was important enough to memorize, and I never got a question specifically asking that on my USMLE. All right, question 11. If you have a high suspicion for subarachnoid hemorrhage, what do you do? Diagnostic workup, CT non-con, boom. You have to know this cold. This is a very, very basic, you have to know if you want to pass the exam type of TQ. But what about if the CT non-con is negative? So CT non-cons of the head are not perfect. They're not going to give you every single subarachnoid hemorrhage. If I had to take a guess, I would say they're over 90% sensitive. But oftentimes, the subarachnoid hemorrhage, if it's very early, you might not see it on the CT yet. So you would want to go ahead and get a CSF analysis, such as a lumbar puncture. And this is going to be something you would do emergently. These lumbar punctures are going to show xanthochromia. You have to know this word. It can show up on your exams. And I've actually seen questions before that specifically tested this fact. So you'll see xanthochromia and increased opening pressure. And so xanthochromia is essentially bilirubin buildup in the CSF from all of your red blood cells bursting and lysing. And so if it's been at least 2 hours since your subarachnoid hemorrhage, you're generally going to be able to start seeing the early signs of xanthochromia. And pretty much after 12 hours, it's generally accepted that 100% of these patients will have xanthochromia present. It's basically the most sensitive indicator in the CSF. All right, number 12. I want you to remember to have a high suspicion for gastroparesis in diabetic patients. So these are patients that have early satiety, nausea, emesis. They're basically puking up undigested food, and they could even have a succussion splash. And so these patients with this gastroparesis, you want to go straight to a gastric emptying study. And so that is maybe an easier type of answer choice, but what if the test gives you a technetium 99M radio-labeled scan? Don't freak out, because that's the same exact thing as saying a gastric emptying study. You basically orally ingest a technetium, and it's going to show you if it passes through your gastric outlet. And so how do you treat gastroparesis? Number one is you want to consider either a D2 receptor antagonist or a motilin agonist. And so metoclopramide is what I go with. That's the D2 receptor antagonist, and erythromycin is the motilin agonist. Generally, in my practice in the hospital, I prescribe metoclopramide more often than erythromycin. Seems like it's relatively well tolerated, but you want to look for extrapyramidal side effects with it. Number 13. Neurofibromatosis 1 patients need to be watched every single year for optic pathway gliomas and Lisch nodules, aka iris hamartomas. And so you have to know that number one, it's yearly eye checkups. Number two, you have to know optic pathway gliomas and Lisch nodules, which are iris hamartomas, are associated with NF1. And so remember, back to step one, neurofibromatosis 1 has complete penetrance and variable expressivity, but it can also appear sporadically in rare instances. So with these patients, you want to check their axilla for freckles. You want to check their inguinal region, basically down in their groins for freckles. And you also want to look for iris hamartomas on physical exam. If you've never seen that before, go ahead and Google iris hamartomas so you can see what it looks like. And you also want to look out for pheochromocytomas. So pheochromocytomas can be highly associated with NF1. All right, bullet point 14. If you see a patient that has precocious puberty, they're basically going through puberty too early, and they have an ovarian mass on imaging, you want to do an oophorectomy. And so basically you go in there, you can often do this laparoscopically and take out the ovary with the mass as well. And so especially if the patient has precocious puberty, you want to have a high suspicion for sex cord stromal tumors. And these can be malignant and cause tons of problems down the line. So you just want to go ahead and take out that ovary. Number 15, this one gets a lot of students. Treatment for tinea capitis is oral griseofulvin or terbinafine. And so with these patients, to work them up, you want to see patchy alopecia, and you can even see black specks all throughout their scalp. And those black dots are basically broken hair follicles. Do not fall for topical answer choices on the test. First line treatment is oral griseofulvin or terbinafine. All right, and just to keep in mind, you don't need to treat other kids or patients that were exposed. You only need to treat the patient that has the tinea capitis. Number 16, what if you see a patient that has mucus infections everywhere? Their sinuses, their airways, upper and lower respiratory infections. They have infertility, otitis media. You want to be thinking some sort of primary ciliary dyskinesia. And so 50% of these patients with PCD will have situs inversus. And remember, take this way back to step one, back to the biochem section of first aid. Cartaginer syndrome is a subset of primary ciliary dyskinesia that has situs inversus, chronic sinusitis, and bronchiectasis. So one thing I was always confused about on step one was, what the heck is bronchiectasis? So bronchiectasis is thick sputum, a cough with irreversibly dilated bronchi. And so on your CT scan, you need to know these buzzwords: tram tracks and signet ring signs on your CT of your chest. And so you can see bronchiectasis in patients with cystic fibrosis, alpha-1 antitrypsin deficiency, Cartaginer, of course, bronchopulmonary aspergillosis, Mycobacterium avium complex infection, as well as severe COPD. So you have to know these. If you see a question stem that gives you the tram tracks, the signet ring signs, or chronically dilated bronchi, you want to start looking for these in your answer choices. All right, 17. When does a dentist need antibiotic prophylaxis before dental procedures? So remember, anything that affects the mucosa of your gums puts you at high risk for infective endocarditis. And so you don't just give prophylactic antibiotics to everybody, but you want to give amoxicillin, which that's a question right there. What's the medication that you would give? It's amoxicillin, but you only want to give it if they have a history of a prosthetic valve, prior episodes of infective endocarditis where the valves could possibly be damaged already at baseline, or if they have a congenital heart disease or required a cardiac transplant with valvulopathy. So those are the only times that you're going to give prophylactic amoxicillin as a dentist. So you need to be able to educate our dental colleagues on this as well as your patients. So the trick is they'll give you a patient that has like aortic stenosis or mitral valve prolapse or tricuspid regurgitation or some sort of murmur, and they'll say, does this patient need amoxicillin? The answer is no. They don't need antibiotic prophylaxis with healthy patients that have, let's say, mitral valve prolapse or aortic stenosis or tricuspid regurg or mitral regurg or anything like that. Only if it's prosthetic valve, prior episodes of infective endocarditis, congenital heart disease, or cardiac transplant with valvulopathy. Those are the four things. All right, number 18. What if you see an overweight child? He has antalgic gait, so he's basically limping along. He's got lower extremity pain. I want you thinking SCFE. And so that's slipped capital femoral epiphysis. And so this is basically a Salter-Harris type 1 fracture of the physis of the bone. And so you want to surgically stabilize the femoral head. So this is a surgical treatment. This is not something that you just give pain meds for, or Tylenol or ibuprofen. You want to surgically stabilize the femoral head in these patients. All right, number 19. Do patients with dementia lack capacity? This is something that you will run across in the hospital, so I wanted to throw this into the mix here. You cannot assume that just because they have dementia that they lack capacity. And so you want to evaluate for capacity basically by seeing if the patient understands, can they weigh the risks and benefits, and can they tell you and verbalize the magnitude of this medical decision upon their outcomes. That's how you basically look for capacity in a patient. And last but not least, number 20, if you see SAD, SAD, so syncope, angina, and dyspnea, plus a murmur, you're thinking aortic stenosis. And just for bonus points, it's going to be a crescendo, decrescendo murmur. All right, guys, those are the 20 most important facts that you need to know from NBME 12. Let me know if this was helpful and I can put together some more reviews like this. Follow me on Twitter. It's twitter.com/action_AP. And if you have any questions or you want some personalized one-on-one help for med school, your boards, getting research, preparing for ERAS, anything like that, shoot me a message or go to actionpotentialmentoring.com and book a free call. This is Dr. Price with Action Potential. Have a fantastic day.